now going to introduce our next speaker, Yetunde Obadeyi, who is a principal optometrist at Moorfields Eye Hospital. And Yetunde Obadeyi has a special interest in glaucoma and also contact lenses. And she will speak today on contact lenses, but with a special emphasis on scleral lenses and how they can be used effectively in Marfan syndrome. Welcome, Ms. Obadeyi. Hello.
Thank you, Victoria. Thank you for inviting me to speak today.
Thank you so much for joining us.
Thank you for inviting me to speak. As Victoria's already said, I'm a principal optometrist. I work in a busy eye hospital in central London, and I have a special interest in contact lenses and glaucoma. And today I've got my contact lens hat on, and we'll be speaking to you about contact lenses in Marfan syndrome, especially focusing on scleral contact lenses. So today I have no financial disclosures. The talk will last about 30 minutes. There'll be time for questions at the end, and just feel free to ask any questions and I'll try my best to answer them. So the objectives of today's session are to be able to describe the specific ocular features of Marfan syndrome where contact lenses may be indicated. You should be able to identify a scleral contact lens and how this differs from standard contact lenses. You should be able to explain the risks and benefits of contact lens wear, and you should be able to recognize where to seek contact lens fitting and care. So there are a number of ocular features of Marfan syndrome in which contact lenses are indicated, and I've given a brief overview here in this slide, but as we go throughout the presentation, I'll discuss these in more detail. But they are ectopia lentis, which is the most predominant ocular feature of Marfan syndrome, where the lens either dislocates, moves into another part of the eye, or the lens is subluxed, so moves slightly off center. High myopia and astigmatism. High myopia is just very high short sight, and astigmatism is when the eye is rugby ball shaped rather than football shaped. Iris transillumination. The iris is the colored bit of the eye, and sometimes you can get defects in the iris, which can cause glare. Flatter corneas. The cornea is the clear window at the front of the eye. That can be flatter than in people without Marfan syndrome. Anisometropia, that is just a difference in prescription between the two eyes. And aphakia, that is when there is no lens, no natural lens at all, no lens at all actually, even intraocular lens, no lens in the eye because it's been taken out by surgical means. So why contact lenses in the first place? Why not glasses? And why contact lenses? Because contact lenses can be superior to glasses in some instances, and a lot of it comes down to optics. So image size is one thing. With contact lenses, images look real size, whereas with glasses, you get a distortion in the image side. So with very high plus lenses, as you can see in this picture, hopefully you can see my cursor, high plus lenses, images look larger. High minus lenses in the picture on the right, on the left, sorry, images look smaller. So glasses give real-time image views. Contact lenses give image sizes that are like the real world. Field of view. In glasses, the field of view can be restricted because when you're not looking through the center of the glasses, you can get distortion. And the frame also, depending on the type of frame you pick, that can also obstruct the field of view, especially if it's a thick frame like in these pictures. Aberrations, you can get aberrations with glasses. So if you wear glasses now, you could try it. When you're looking through the center of your glasses, the view should be clear. If you look right at the edge of the lens, you might see blurred vision, you might see colored fringes, you may see distortion, and this is just because of the optics of the lens. There are aberrations towards the periphery. Contact lenses, because they move with the eye, they sit on the eye, they're always, usually it's fitting well central, you don't get these aberrations. Aesthetics, lots of people like to be glasses free, although glasses are quite fashionable now, and I've noticed that Victoria had some lovely glasses, so that might not be a problem for everyone. Comfort, with these high prescriptions, high myopia or aphakia, the glasses are very heavy. They can be uncomfortable on the nose and on the back of the ears. So with contact lenses, you don't get that. There's nothing on the face at all, although with some contact lenses, it can take some time to adapt to them. And then vision, especially with anisometropia, with a difference in the two eyes, the vision is very uncomfortable, imbalanced in glasses. You can get headaches, you can get eye strain. With contact lenses, you don't get these problems because the image sizes in both eyes are the same. So types of contact lenses available. There are essentially 3 types of lenses: soft contact lenses, hard contact lenses, and a mixture of the two called hybrid lenses. So soft contact lenses, most people are familiar with the soft contact lenses, which are readily available. You can get them from your community optometrist. They come in a range of prescriptions from mild to moderate, long sight and short sight, and mild to moderate astigmatism. You can get ones that you throw away at the end of each day, or ones that you keep for a month. But these come in standard prescriptions and standard parameters. You can also get cosmetic lenses with a tint, and these are 2 types of cosmetic lenses in the picture on the screen. The brown lens, you can actually see through. That's a homogeneous tint, and you can get it in different levels of intensity, and this is good for glare. And then the other lens, the blue lens, has a painted iris. People use these lenses just to change the iris color, but they're actually useful because you can change the aperture size, the clear pupil size, to be able to manipulate the vision and give clearer vision in some instances, which we'll discuss later on. And then there's hybrid lenses, a mixture of hard and soft. Usually the center is hard and then the outside skirt is soft. They come in a larger range of prescriptions and soft lenses, and the soft skirt makes them more comfortable. So hard contact lenses, they're also known as rigid gas permeable lenses, and they're called gas permeable because the older generation lenses were made of a perspex, which allowed no oxygen to transmit through the lens to the eye. These rigid gas permeable lenses allow oxygen to nourish the eye, which is great, but they're hard, so they're quite uncomfortable initially, and patients do take some time to adapt to them. They range in diameter. You can get as small as 8 millimeters, which are corneal lenses. They sit within the cornea. You can get a bit bigger corneal scleral lenses. They sit a little bit onto the sclera, the white bit of the eye. They go up to about 14.5 millimeters. And then you go into the scleral range, which sit firmly on the sclera. You can get mini scleral lenses up to 18 millimeters, and then full diameter sclerals up to 23 millimeters. And scleral lenses sit on the sclera, which is the white bit on the eye, hence their name. So this is an image of a scleral contact lens. As you can see, the lens, you can see my cursor, this is the edge of the lens. It takes up pretty much the whole of the visible sclera at the front of the eye. So how are scleral lenses different from other contact lenses? Scleral lenses are not new. They've been around for quite a long time. The earliest mentions were about in the late 1880s, where the first scleral lenses were made of glass. And obviously having glass in your eye would be awful. Imagine if you had an injury. It's not a good idea at all. So now these newer lenses made of plastic, a mixture of fluorine, silicone, and acrylic. And you fill them up with fluid, as you can see in the picture. I hope you can see that lens is filled with fluid. They bridge the cornea, so they don't touch the cornea, the clear window at the front of the eye. They just sit firmly on the sclera, like we saw in the previous picture. And that's great, because if there is a compromised cornea, these scleral lenses are great because the lenses don't touch the eye at all. You fill them up with saline to wear them, and that fluid is in contact with the eye all the time, and that's what corrects the vision. Having a fluid reservoir behind the lens, as well as the smooth optical front surface the lens creates. The lens is a large diameter, which means that actually, surprisingly, they're quite comfortable because they don't sit on the cornea, and the cornea contains most of the nerves that will cause sensation. They come in a large range of prescriptions, much larger than you can get in standard contact lenses. We can make custom-made scleral lenses, so we can often we take casts of the eye with dental mold, and then we can reproduce a scleral lens from a cast. Or newer technology, we can scan the cornea and scan the sclera, and we can design a custom-made scleral lens that fits like a glove. We can also use imaging to assist with scleral contact lens fitting. You may have heard of an OCT to scan the retina. We can use anterior segment OCT to scan the front of the eye to assist contact lens fitting in scleral lenses. And then finally, these lenses are not disposable. Many patients keep their lenses for years. As long as they're cleaned and kept well, you can keep them for one lens for many, many years. I've just got a short video demonstrating how scleral lenses are inserted and removed. Wow. I'm not sure. Can you hear the video at all?
I don't think
I don't think we can hear it.
No, okay, just bear with me.
While gently rubbing it between your fingers. While gently rubbing it between your lens plus Occupore saline or an alternative unpreserved saline solution. Lean forward so that your face is parallel to the floor and look as far as possible towards your chin to avoid spilling the saline. Pull your upper lid up with the index finger of your other hand. Slide the lens under your upper lid, making sure to keep looking towards your chin. When the lens is under your upper lid, physically close your lid over the lens with your other hand and let go of the lens at the same time, while still holding your top lid over the lens. You can then pull your lower lid over the lens with your free hand. When the lens is in place under both lids, look up slowly. Wash and dry your hands thoroughly before removing your lenses. Look down, keeping your chin upwards, and lift your upper lid on the side nearest your nose with your index finger so that the lid is above the upper rim of the lens. Press downwards and then tighten the lid by drawing your finger towards your temple. This action will push the lid underneath the edge of the lens, releasing the suction. Keep pulling towards your temple to get the lens to come out from your eye and catch it with your other hand. Alternatively, do this over a table covered with a towel to prevent the lens falling on the floor. Alternatively, you can use a suction holder to remove your contact lens.
Okay, so we're going to go back to those conditions that we discussed earlier. Ectopia lentis, this is the most prevalent ocular feature of Marfan syndrome. And this is where, so the first picture is where the eye, the lens, the crystalline lens, the natural lens that we're born with is in the normal position. And in Marfan syndrome, because the zonular fibers contain fibrillin, these are weakened and the lens can be subluxed, so it moves away from its normal position, usually superior temporally, or the lens can completely dislocate and goes into a different portion of the eye, and that is when the eye is aphakic, and that's in the final picture. So these are some pictures of a real eye with ectopia lentis. You should be able to see the lens here, and then you can see the zonular fibers in the first two pictures here. And depending on which section of the eye you're looking through, so if you're looking through where the zonules are, you may have a strong plus prescription. If you are looking through the portion of the eye that has the lens, you may have a strong minus prescription and astigmatism, because when the lens is subluxed, the lens also tilts, and this induces lenticular astigmatism. So sometimes you might have corneal astigmatism, but tilting of the lens induces lenticular astigmatism. Contact lenses, as we discussed with high prescriptions, contact lenses are often more appropriate. So you can, if you're looking through this portion with the zonules, contact lenses will be appropriate. However, if you're looking through this portion, we might want to get rid of the edge of the lens that causes distortions and astigmatism. So we may choose that lens with a small pupil, with a pointed iris, just to kind of give you a pinhole effect. And ensure you're looking through the correct portion of the lens and removing that peripheral distortion. Iris transillumination, this is a picture of iris transillumination. It's quite marked, it's often very subtle. And this is where there's loss of the iris pigment epithelium, so light passes unobstructedly through the parts of the iris that have lost the iris pigment to the retina. Usually light should only pass through the pupil, but because of the defects in the iris, you can get glare. And then contact lenses can be indicated, so that tinted contact lens with a homogeneous tint would be useful to eliminate glare. And they come in different intensities, from 10%, 5% even, to 40% tints, and in a range of different colors. Usually, these tinted contact lenses are only indicated if glare is a problem indoors and outdoors. If it's just a problem outdoors, contact lenses will not really be recommended or indicated. We talked about high myopia and astigmatism. So Marfan syndrome is associated with a longer axial length, that's a longer eye, which is associated with high short sight. And the astigmatism can occur because of that tilt in the lens, the subluxation of the lens we discussed. With contact lenses, because the image size is like a real object, like that of a real object, whereas glasses, it's minified, as you can see in the picture. Often you get clearer vision with contact lenses than with glasses in myopia. And also the distortion you can get from the astigmatism can often correct that more easily with the contact lenses. Just as a caveat, sometimes contact lenses can create their own distortions and aberrations, just depending on how the lens is tilted. Aphakia is with no lens in the eye. Images look bigger in glasses. They're more real size in contact lenses. In children, we do recommend to continue on with glasses because they can get used to this bigger image size, but in adulthood, often this is a problem, and contact lenses are a better option. And also the glasses are quite bulky and heavy, and contact lenses, you don't get this problem. Marfan syndrome is also associated with a flatter cornea, so the clear window at the front of the eye is flatter than in people without Marfan syndrome. So often those standard soft contact lenses, they're quite difficult to get a good fit sometimes in some instances. So these are where the hard or scleral contact lenses will be indicated because we can get them in a wider range of parameters. And then we discussed the anisometropia. One of my colleagues recently had a case of a patient with Marfan syndrome who was aphakia in one eye and high myopia and astigmatism in the other eye. It's impossible to have a high plus and a high minus in either eye in glasses. It's just, you'll be very imbalanced and it'll cause lots of problems. So contact lenses are definitely indicated there to create some balance. So we discussed all the good things about contact lenses, but there are some risks with contact lenses. The most serious risk is a sight-threatening eye infection as a result of contact lens wear. It's rare, but it can happen, and really more associated with overnight wear of contact lenses, which we don't recommend, or with poor contact lens hygiene. And the signs of this serious infection are the vision is very blurred, the eye is red, painful, lots of discharge, and that's an ophthalmic emergency. You can get dry eyes with contact lenses because contact lenses disrupt the tear film, and lots of the soft contact lenses contain water, and the lenses dry out towards the end of the day. Lots of people use lubricating eye drops because, especially with computer use, scleral lenses actually solve this problem because we're filling up the lens with saline. That saline is in contact with the eye all day, and it kind of creates a constant lubrication to the surface of the eye. So we actually use scleral contact lenses therapeutically for patients with chronic dry eye. Contact lenses can also cause corneal edema, that's swelling of the clear window at the front of the eye, can happen in scleral lenses, because there's a barrier to oxygen, there's a barrier to atmospheric oxygen getting into the eye because of the lens. The cornea can swell, it can be a bit painful, you can get blurred vision, but this resolves when the lens is removed. But it might mean that we have to alter the wear time, reduce the time that people wear lenses for. Another complication of contact lens wear is giant papillary conjunctivitis. We call this GPC, and this is an allergic reaction to deposits or proteins on the surface of the contact lens. These lenses, as I said, you can keep them for years and years, and they're not disposable, so you can get an allergic reaction that manifests as bumps underneath the lid. This is a picture of GPC. There's bumps underneath the upper lid, which is due to an allergic reaction. and there is some mucus discharge there also. And in this case, you'll get a very itchy eye, red eye, and may have to cease contact lens wear or change the contact lens, reduce your wear time or change it to a different type of contact lens if not able to resolve this. So where to seek contact lens care? The first point of call is the local optometrist, because the majority of prescriptions and the majority of patients with Marfan syndrome can be fitted locally with the local optometrist. It's only the most complex prescriptions that need to be fitted in the hospital eye service. The best place to find a local practitioner is the BCLA website, the website of the British Contact Lens Association, where you can find a practitioner near you with a special interest in contact lenses. And I've just put their website address there, www.bcla.org.uk. For the hospital eye service, we'll only see the most complex cases and cases with very high prescriptions. You would need a referral from your local optometrist to be seen in the hospital or your GP. And if you do get seen in the hospital eye service, it may not automatically be scleral contact lenses. We might go to try more custom-made soft contact lenses or even a corneal lens, and before going on to a scleral lens. Usually scleral lens is usually the last resort in the hospital eye service. And then we talked about that sight-threatening complication of contact lens wear, the corneal infection or microbial keratitis. That is an ophthalmic emergency and needs urgent assessment in eye casualty. So you should now be able to describe the ocular features of Marfan syndrome, where contact lenses are indicated. We talked about the most common or prevalent feature, which is ectopia lentis. We've talked about aphakia as well, where high plus lenses are required and contact lenses are beneficial. We talked about iris transillumination, where tinted lenses are also beneficial. And then we've talked about scleral contact lenses, where if the prescription is very high or an adequate fit is not achievable with standard contact lenses, and scleral lenses are indicated. You should be able to identify a scleral contact lens now. It's a larger diameter, up to 23 millimeters. Fill it up with fluid. It doesn't touch the cornea, it bridges the cornea, sits on the sclera. You should also be able to explain the benefits and risks of contact lens wear. Contact lenses create image sizes more similar to the real world, where glasses distort this image size. The main risk is the infection that we talked about. You can also get allergies, you can get corneal edema, you can get dry eye. However, scleral lenses help with dry eye because of that fluid reservoir. And then you should also be able to recognize where to seek care and contact lens fitting. The first point of call is always the community optometrist, and then more complex cases are referred into the hospital eye service. So I'm happy to take any questions.
Thank you so much for that comprehensive overview. I'm examining the chat feed for questions. Does anyone have a question? Actually, I do.
I have a question, Victoria.
Oh, yes.
Oh, may I? But I'll let you go first, and I have another question after that.
My question was more general about the elusivity, it seems, of scleral lenses. One patient loves his scleral lenses. They're custom made, but only in Moorfields, and he lives in Wales. And he finds that he has to wait impatiently for his next sort of set of lenses. So it's a comment, really, not a question.
I mean, traditionally, scleral lenses have been quite elusive and restricted to the hospital eye service. But in the last 10 or so years, more and more becoming more popular. And I think we're going to see it more readily available in community optometrists.
Excellent, I think. Professor Ninaba, did you?
Yeah, I have a question to Yetunde. I'm very not only surprised, but I'm really pleased with your overview of the options that we have so far, and for our patients and for everybody else as well. In a Marfan patient who had already a placement of his or her lenses due to aphakia, would there be an option with an additional contact lens to restore some sort of accommodation? Because accommodation cannot be provided by the implanted lenses, right?
Yeah, that's a great question. Yes, so there are contact lenses that correct presbyopia or accommodation. There are contact lenses available, usually soft contact lenses. So that is a possibility.
And how would that work?
So So it's a bit complex, but there are concentric rings within the contact lenses, a ring for near, a ring for distance, and depending on pupil size as well, this is how it works. So depending on how big the pupil is, you're either looking through the center, the distance portion, or the near portion.
I see. Thank you.
Questions are flooding in. Amanda wants to know, what are the disadvantages of scleral lenses? She's been wearing soft lenses successfully for over 20 years, but as she gets older, her eyes are getting drier.
Okay. Scleral lenses are quite big, as you saw in the picture, so they can add some bulk to the eye. So the eye can look more bulky than without a contact lens. The lens, you keep it for quite a long time, so it can be kept for many years. And with the soft disposable lenses, because you're throwing them away, potentially less risk of infection with the disposable throwaway lenses, because you're putting a fresh lens in the eye every day. And then with scleral contact lenses, they're more specialist, so it's harder to get the lenses because they're mainly fitted in the hospital eye service, although that's changing now.
And Nicola wants to know, if you have glaucoma, can you still use contact lenses? Her son has drops twice a day, so would lenses cause infection?
You can use contact lenses with glaucoma. But the drops should be preservative-free, unless you are using the hard lock contact lenses, in which case sometimes you can put the drops in 5 minutes before you put the contact lenses in, and then when you take the contact lenses out at night, you can put the remaining drops in.
Val would like to, could you comment on, or say something about contact lenses in children?
We fit contact lenses in children. We fit babies in the hospital who have aphakia from weeks old, so it's not a problem. I think older children, maybe 10 or to 16, probably need supervision, especially with the cleaning. It's really important that parents supervise because of the risk of infection.
And for conditions where soft contact lenses and glasses are needed, is it likely that scleral lenses could meet the whole prescription without glasses?
It's very case dependent. A lot of the even with scleral lenses, we do use top-up glasses sometimes, because as I mentioned in my talk briefly, contact lenses still can create their own aberrations, and sometimes glasses are still needed. But they won't be as thick, obviously. Yeah.
And I don't know, I think you may have answered this already. When is it recommended for children with Marfan to start wearing contact lenses?
So I would say it would be only indicated if better vision is, if the child gets better vision in contact lenses than glasses. If the vision is good in glasses, there's absolutely no need for a child to wear contact lenses unless they want it for recreational purposes, for sports, etc. But if the vision is good in glasses, the best thing is to remain in glasses. And when the child is older and can look after the contact lens, then they can get contact lenses at their own discretion.
And then finally, would you recommend laser eye surgery for people with Marfan who are short-sighted?
This is tricky because it depends on what the position of the lens and whether the lens is subluxed yet, or yeah, it depends. It's very case dependent. You would have to have a separate consultation for laser eye surgery. I can't answer that question quite straightforward. Yeah.
Okay, thank you so much. I don't think any further questions are emerging. Thank you so much, Yetunde. That was brilliant.
Thank you very much. Thank you for inviting me.
Thank you so much. Thank you.